Good evening, everybody, and welcome to the Institute of Politics. We are delighted tonight to have Congressman Patrick Kennedy here to talk to us about the politics of mental health care and the change we need to see on our political landscape. I'm going to let Brian Schwartz do an official introduction, but before I do, I just want to tell you about a couple of upcoming events we have. Next week, we have a very full week. On Monday, Time Magazine Washington correspondent J. Newton Small will be here to talk about the critical mass that we're achieving of women in politics and corporate leadership, and how that is going to change the way things are run in this country. We hope for the better. We think for the better. On Tuesday night, we will be having a debate on the Second Amendment hosted by FIRE. This will be on should we change the Second Amendment. On Wednesday, Frank Bruni's going to be here talking about who created Donald Trump, and is the media to blame, or are we to blame for that? And then on Thursday, we will round out the week with a screening with Oliver Stone. So we're going to all look at American politics from all sides next week. But tonight, I'd like to introduce Brian Schwartz, who will make the introductions. He's a second-year student at the University of Chicago. He's majoring in molecular engineering, and he's from Southampton, New York. And most importantly, he's the vice president of the Maroon Veterans Alliance, which is one of our community action projects within the IOP, and has been working to establish a student-led medical support and career advocacy program for returning veterans and their families. So without further ado, Brian.
Thank you so much, Alicia, for that wonderful introduction. So it's with great pleasure to introduce the Honorable Patrick J. Kennedy and welcome him to the University of Chicago. The son of Senator Edward Kennedy, Mr. Kennedy was elected to the Rhode Island House of Representatives at the age of 21. He would then go on to represent the 1st Congressional District of Rhode Island in Washington for 16 years. While in Congress, he served on the Armed Services and Natural Resources Committees before being appointed to the Appropriations Committee. From 1999 to 2001, he also served as the chair of the Democratic Congressional Campaign Committee. During his tenure in Congress, he fought a national battle to end medical and societal discrimination against mental illness, addiction, and other brain diseases. This is showcased by his lead on the Mental Health Parity and Addiction Equity Act of 2008, which was enacted in October of that year. He decided to leave Congress in 2011 and has since then devoted his career to advocacy for brain diseases and policy for mental health. He founded the Kennedy Forum, which unites the community of mental health advocacy to push for a policy change. Additionally, he co-founded One Mind for Research, a global leader in open science collaboration in brain research. Thank you, sir, for speaking here about the issues regarding mental health care in today's world. It is an honor to have you at the University of Chicago Institute of Politics. Tonight's discussion will be led by Forbes healthcare journalist and author of Inside Obamacare, The Fix for America's Ailing Healthcare System, Bruce Japsen. Please join me in giving a warm welcome to Mr. Japsen and the Honorable Patrick Kennedy.
Thanks. Thank you so much. It's great to be here. I mean, I know there's a lot of students in the audience, and I just wanted to say, as a journalist who's written about healthcare in Chicago for 23 years, what you may not know is that we all know that the President of the United States has history here, but his wife, just 10 years ago, last November, I interviewed her in one of those buildings over there when she was the Vice President of Public Affairs, and she was involved in one of the nation's first medical homes. It was called the Urban Health Initiative, where it wasn't all about just health insurance and getting people, but making sure that the care gets to you. So it's so cool to be back here and to be part of an effort where we have with us a congressman who was involved in carrying some of the Obama's early envisions for healthcare through with 2 of the most significant pieces of healthcare legislation, probably since the passage of Medicare back in the 60s. So with that, I wanted to talk to the congressman a little bit. We mentioned the mental health parity law and also the Affordable Care Act. And I think a lot of people think like, well, we still have issues. I mean, there's coverage for everything, then why are we still having suicide rates so high? And if you could start off by telling a little bit about your your personal story, because some people might say that, even though you're still in your 40s, your work should be done. All these things have passed. So if you could talk.
Well, thank you. I also want to make sure that I thank all of you for coming. This is a huge turnout for a subject that gets too little attention. So I appreciate everybody being here. And I thank the IOP, and I thank Brian for the introduction and for doing what he's doing for veterans with his organization here. So I don't know really where to go with that. I love to talk. I'm a former politician, so I could ramble on and on about. You asked kind of two questions: my personal story and why we're still in a state of crisis in this country in mental health. So the reason simply that we're still in a crisis is we don't do what works in mental health. That's it. We don't do what works. And part of the reason we don't do what works is because we don't enforce the law. And the reason we don't enforce the law is the insurance companies have a stranglehold over both the administration and Congress. That's the answer. Insurance companies were the ones that brought the ACA to existence, and president has to dance with the ones that brought them. And it's big insurance. So there has been a reluctance on the administration's part to really step on the toes of the ones that brought you to the dance. They've been struggling to try to keep the ACA alive, and through these court challenges, through all these political challenges. And so they haven't wanted to add to kind of the challenge of, pushing anything that might seem to the insurance industry as, heavy-handed by the government. So as a result, insurance companies continue to practice discrimination. They practice it because they know they can get away with it, because no one's going to appeal a denial, because very few people go and actually access mental health care to begin with. And if they do and they get rejected, they kind of go home and say, I'm not worthy. No one's there to fight for them. And even if they are, you need like a master's PhD to navigate the appeals process. And so it's all baked into the risk cost benefit analysis from an insurance company. They don't have to worry about this. They just do a lot of pre-authorization and medical managed care, and basically no one gets help. Suicide rates are twice homicide rates. Overdose rates surpass car accidents. We're losing 23 veterans a day. We're kind of got a head in the sand. I mean, it's shocking. And, we set up new suicide hotlines or whatever. We don't need to be doing any. We just need to cover brain health like we would any other physical health issue, which means you cover it early, you screen for it early, you treat it early, just like you would with diabetes, just like you would with cancer, just like we do with cardiovascular disease. We don't do that. We wait until you get really sick, and then maybe we cover you. That's the status of mental health. So no wonder so many people are dying of overdose. No wonder so many people are successfully completing suicide. And that's the 42,000 that we know of. Because as you know, most people don't want to have their family registered as having completed suicide. So many of the suicides are actually written off as something else. So, that is a really sad state of affairs. And it's in this 2016 that we're still living with this notion that it's this old idea that these are moral failings of the individual as opposed to medical issues. And that pervades all of our public policy, our attitudes, coverage, everything. And it's the reason we're in the state that we're in.
So do you think, could you talk a little bit about your personal story and how you arrived to do this after Congress? I mean, having been involved in legislation, and you have a memoir out that was controversial to talk a little bit about. Could you tell a little bit about that and how that plays into what you're doing with the policy?
Sure. So I'm in recovery from addiction, alcoholism. I have a mood disorder. It's a miracle that I'm sitting up here on the stage. I, was arrested by the airport security, by the Coast Guard, by Capitol Police, all in my, time up on the Hill. I mean, there wasn't anywhere I could go where I wasn't getting arrested, basically, because, if you have these illnesses, that's what happens. In fact, tomorrow I'm going to be speaking at a national convention of CIT officers. This notion that we have law enforcement and very few of them are actually trained in dealing with what they deal with most, which is people with untreated mental illness and addiction. And the notion that even the Chicago police, which thanks to the mayor, has actually taken on this kind of training and really looking to bring it to all first responders in the city of Chicago. The notion that we're still, in this day and age, not looking at mental health as something core to what a law enforcement officer has to be trained in order to deal with. But that being said, I struggled my whole time in Congress and before. Some times are better than others. My last about 5 or 6 years in office, it got progressively worse. The severity of my illness just kept getting worse and worse. And as I said, I was lucky to make it out of Congress alive. A lot of people worried when I left Congress what that would mean, because I no longer had any reason to try to hold it together. Because when I was in public life, I still had, some sense, well, I got to keep this from everybody. The notion was when I got out of Congress that it would be free reign. And I almost went off the deep end, but I was also very fortunate. I met this incredible woman about a year before I left Congress. And I kind of got a fairy tale story about how we got married. And I have put together the longest period of continuous sobriety in my whole life since leaving Congress. But it argues the fact that, a lot of people can successfully, so to speak, manage their lives and still, hold positions of power in business and politics and academia. The big misnomer about mental health and addiction is it's just those people. These illnesses affect everybody and in very varying degrees. So I was probably too functional for my own good, but then became really dysfunctional. Unfortunately, at the very end, as I said, I barely made it out of that place with my life and also without a major political scandal, because I was heading for one because my inability to manage my addiction was so deep. And ironically, you're David Axelrod, who was my political consultant my whole life. I tell everybody that I'm the one who gave him his political start, because he was my political consultant before he was President Obama's. And President Obama needed to really make sure that he was tested. And I did everything I could to get him ready for the big time. So David, I filmed my announcement that I wasn't going to run for re-election in David Axelrod's house here in Chicago, all under the cover of darkness. And then we did, anonymous media buy in Rhode Island TV market. And that's how I announced my decision, because I knew, given what everyone knew about my struggles, that the moment I stepped in front of a phalanx of reporters and said I wasn't going to run for re-election, all the story would be is, plagued by addiction, saddled with this, just be all, negative Nancy. And instead, I actually got to get some story out there. It was kind of more full in its approach. So anyway, I have a book where I take a deep dive into how I was bringing vodka and water bottles to work, how I passed out on the floor of the house under the influence of benzodiazepines, how I would put all my Oxycontins in a, bare aspirin bottle, so no one would know that I was taking them. I had all the usual tricks that you hear about from someone who suffers from addiction. and alcoholism. And so I tell all those stories. So it is really interesting reading. If anybody's interested in buying the book, you will really it'll be gripping for you. So it's called A Common Struggle. So.
Well, so if you could maybe walk us through, so these laws are complicated. The Mental Health Parity and Addiction Act that was signed into law by President Bush that you were involved in, and then the Affordable Care Act gives more people health care coverage. So under the Mental Health Parity Act, if you have access to 10 visits a year with your primary care physician, under the Mental Health Parity Act, you should have 10 visits a year to a therapist. But that's not happening. Could you walk us through maybe one of the common challenges?
Sure. So the law basically said you couldn't have any higher co-pays, higher deductibles, higher premiums, lower lifetime caps, or pre-existing condition requirements for treatment and coverage of mental illness and addiction.
So if you had the issues you had, you couldn't be denied care.
I couldn't be denied, and I couldn't be denied through financial limitations, which was what we did away with, the premiums, deductibles, co-pays. But it also said you couldn't be denied on treatment limitations. And that's the part that we're dealing with now, is facing the way the insurance companies have an insidious denial of equal coverage. And in the law says if you're inpatient in-network or outpatient in-network or inpatient out-of-network or outpatient out-of-network, or you need emergency room or ER benefits, you must provide the same levels of care commensurate with the severity of your illness that you would receive if you had severity of illness of any other type of organ in your body. So basically that's what the law says. So, they don't do the kind of medical management for you if you come in with diabetes or cardiovascular disease or cancer, but they routinely deny care in a number of ways known as non-quantitative treatment limits. And that's a lot of that is pre-authorization, what's known as fail first, those types of things. And of course, there is a limited access to mental health and addiction services because the pay is so much less for mental health specialists, which is the reason why so fewer of them are in network, and then that forces people out of network. And then, of course, you've got to run up a big, copay or deductible in order to get care, and you're not really sure you want to get care anyway. So that's the reason why people don't get care, and then they get really sick, and then they get into trouble. Our whole system is the inverse of what we need it to be, and that is it's all reactionary, crisis-oriented still, even though the whole concept of healthcare reform is to treat people early and preemptively. We're still in a state where we're in a reactive mode.
So when people say, and the insurance companies would say, well, we're going to this value-based care, and we're moving away from fee-for-service medicine, where the more volume, the more money a provider makes. That's not going on with mental health?
It's very slow. So the ACO model, as it relates to behavioral health,
that's an accountable care organization.
Accountable care organization, very slow uptake. Although there is beginning to be a recognition for what's always been known, and that is mental health issues underlie practically every other physical health issue. And if you really want to rein in costs for treating diabetes or cardiovascular disease, cancer, anything else, if you address by first identifying anxiety, depression, addiction, then you're going to reduce substantially the cost of treating the physical health condition. So the irony is, in the past, mental health was always a carve-out, meaning it was just seen as an extra expense. It wasn't seen in the context of the savings that would be gotten from incorporating it and integrating it into the rest of physical health care. So if you carve it out, it means you don't see the benefit on the books on the physical health side. as you would if it were the whole person. That's now, seen as needing to be changed. But to change it, it takes a long time. Unfortunately, people are suffering in the interim.
I do want to explain accountable care organization because that's one of my passions, and you could probably get an A on a term paper if you did a strat. So if this is a room of 200 people, and I'm an insurance company, and you're all in my plan, okay? The old way was just fee for service, the costs go up, doctors and the insurance company pays. Now they're moving to this model where the insurance company or employer contracts with a group of doctors and hospitals and hopefully mental health providers. And if it cost $1 million to take care of all you guys this year, if next year they reduced that cost to $500,000 and made sure you got all your care and hit various quality members, they would get to keep the half of the $500,000 saved. There you go. Anyway, so it should work in mental health, but you're saying they carve it out and they don't.
In the past, they've carved it out, but I do think that it will be the way that insurance companies actually get the benefit of real health care reform. The benefit in real health care reform is going to be in the mental health space. That's where the gold is. That's where the money is. Honestly speaking, we're ill-equipped. We don't have the thinking. We don't have the capacity. It's not in our culture to think about this whole person health, but that is where the money is. And the people who get their arms around it in the business world are going to be the people who make the biggest killing in terms of healthcare.
And one of the things he would talk about, this is actually something that Mrs. Obama was involved in. So if you have someone with mental health issues and addiction, could be a homeless person, they have a Medicaid card, and they would show up to the University of Chicago emergency room. It could be they would come 10 times a month. And every time they would come, they would have to get admitted. And the cost of the system are tens of thousands of dollars. Under the new system that he's talking about, they would get hooked up with a primary care provider, a counselor, a case manager to make sure they're getting what they need so they don't show up at the emergency room. Are we getting there with that?
So we're beginning to get there. There's some structural impediments, one of which is this hangover from the past where we would preclude the sharing of information if you were in drug and alcohol treatment. In other words, that's not part of your medical record. That needs to change. In terms of mental health, the families are still not involved in the kind of coordinated care that you would have families involved in if they were taking care of a loved one returning from a hospital from open heart surgery. So there are some old, systematic impediments to real coordinated care, one of which is the fact that if you've been in treatment, that's not shared with the rest of your physical health record. And two, that family members are really not involved in the coordination of your care.
If you had and we're going to open it up to questions in about 5 minutes because I want to make this a big crowd here. I want to get your questions. If you knew someone who had issues and didn't know how to navigate the system, what would your advice be to someone here if they knew that they had a family member or someone with a problem? What would be one of the key things you would tell them to do in dealing with their insurance company?
Well, first, you can't do any of this alone. So, first, I think it's really useful for people to recognize these are family diseases. In other words, it affects the whole family. That even if it's a friend, you're affected, that you should get some help for yourself. And you also would get networked with others that have been through similar experiences as you are going through, and that could help you get hooked up with the right resources. So I have people in audiences all the time, cry, they've got their loved one, can't get treatment, they don't know what to do, and they're like a mess. and they never thought that they're affected too. And I say, maybe you should think about Al-Anon's great, it's good 12-step recovery for you. You might be, and they're like, well, I wasn't asking about me. I want to know how I can help my loved one who can't get it together. And then all of a sudden they recognize that they need help too, and that they can get support from that peer support system to help them figure out also how to help their loved one. We need an Angie's list for mental health and addiction. We really do. And it's shocking to me, because my email blows up every day with people calling me, asking me to help them get into this treatment center, or is this the right one, or isn't it? Or how do I get a doctor in the local community? I mean, we are bereft of good resource guides for good mental health providers too. We also don't know how to identify who's good and who isn't in the mental health space. It's a one-size-fits-all approach. No one has to do outcomes-based metrics, so you have no idea who's a good psychiatrist versus a bad psychiatrist, good psychologist for a bad psychologist. No way to know whether this therapy is better than that therapy for your particular diagnoses. And it's shocking when you think about the size of this disability that we don't have more sophistication in this space to allow consumers, to answer your question, to have a pretty good set of directions on how to get help for themselves or for their loved one. It's shocking in this day and age that's, the best you can do is, I know somebody and they're a psychiatrist, maybe they'll take you in 6 weeks at the earliest. That's the kind of usual answer.
I'm going to ask one more question, then we're going to open it up to questions. This is a politics institute, and there is an election going on, in case you haven't heard. Have you examined the 4 or 5, there'll probably be maybe 4 after tonight, maybe 3. The plans of those running for president, is mental health being addressed by all of them or any of them? And I write about the space, and I
it's surprising that what's passed as a breakthrough in this campaign is that you've had some of the candidates talk about their personal experiences. And everybody's like, oh my God, isn't that great? Ted Cruz talks about his sister, and you've got, Bush talked about his daughter, and you've got, Trump talked about his brother. And I mean, you've got all these, but so what? Like, tell me, what are you going to do? Don't tell me you identify. If you do identify, then you ought to say, okay, I know this issue. It's personal to me. It's affected my family. Here's what I'm going to do when I'm elected president. Boom. I mean, by the way, that candidate would have a defining, distinguishing, characteristic that would separate them from all the other candidates. And has any one of them done it? No. Now, Hillary's the only one who has a policy shop to speak of, frankly. No other candidate, remarkably, in this presidential campaign. It used to be you had to actually know what you were talking about and have policy positions that were well developed, and where you put really smart people in a room and really got them to churn out these white papers. That's been pretty much non-existent in this presidential campaign. Hillary, to her credit, has had that. I mean, she's run the campaign based upon that kind of model of putting together a strong back room. So she has she's put out a plan to significantly improve prevention, which is really where the gold standard for all of this, is early intervention and prevention. She's got a very good public health model that she's pushing out there. But honestly, I'm still, given the size and scope of this issue, I've been shocked that she's not really come out in a major way and just grabbed this issue with, and really spoken to this issue the way I think any candidate should, and that none of them really have, and giving it a narrative, because anyway. So some things that I don't like about what she's done is she supported the expansion of commercialization of marijuana, which practically every Democrat does anyway these days. So she's not alone. Bernie Sanders is probably even worse on that.
And why is that bad?
Well, we've had our problems. Not for nothing, we're a country that loves our addictions, aren't we, as Americans? We love alcohol, and boy, doesn't that rip us up.
And no one really speaks
and then
out
we
about that.
loved our tobacco, and then that kills so many of us. And we love our Oxycontin, and we love our benzodiazepines. There's plenty of addiction to go around. I just, the notion that we're going to have a for-profit new big tobacco whose main bottom line is going to drive the sale of a new intoxicant. That's the way I look at it. And that intoxicant's going to come in the form of elixirs. I don't know if you've heard about these. It's like grape soda, strawberry soda with THC in it. That's what they're selling in Colorado and Washington State. Edibles, I don't know if you've ever heard of what an edible is. Edible is any food stuff that you can think of with THC in it. And it's all wrapped up. You've got pot tarts and a whole host of like-minded both candies and, all wrapped with shiny, glittery, colorful wrapping to target kids. And my big thing is most people, like with alcohol, 80% can drink, without having to binge. But 20% of the drinkers make up 80% of the profits for the liquor industry. It's the alcoholics, people like me, just when I was out there. They lost out big when I got on the wagon. That's all I can say. And in marijuana, it's going to be the same. A lot of people can take it and leave it. But there'll be some people, especially with the fact that the age of first access to this is getting, the prevalence is getting so great, that there's going to be a certain percentage that are going to be predisposed to both psychosis, because as you know, the THC precipitates psychosis. If you have a determination to have some kind of mental illness, this could really end up tripping it off. But, or addiction. And then those folks are going to be particularly vulnerable. And I just don't like the idea of Wall Street big money making money off of addiction. That's basically, we're going to have a new addiction, industry. And I'm for decriminalization. I led the effort for drug courts, mental health courts. I'm all for this, an addiction space to all be moving towards public health and screening and treatment. So I have pretty strong credentials that I'm not about people getting locked up. This is not where I come from. But I am sure that this thing is going to be a fast freight train to a new addictive industry that I just don't think is good for our country.
That's great. Let's open it up to questions if somebody wants to go, and the mic is in the middle. Yes. If you want to say where you're from and who you are, that's fine. But
sure. My name is Judy Weiss. I'm a healthcare activist working for a single-payer system. And so I appreciate your willingness to talk about this issue, and especially to say from the get-go, to identify the obstructionist role of the insurance companies.
Yes.
Which is why I'm kind of puzzled by your support of accountable care organizations, which are the insurance companies running our health care. I mean, aside from the responsibility to their shareholders and to make a profit.
Just point of order, the accountable care organization is actually the providers, the doctors and hospitals, and they contract with the insurance companies.
Okay.
But go ahead.
They are the network that right?
Yeah, part of that's.
And one,
yeah.
all right, well, that brings me to one of the biggest problems with that is that people, if you had something like that was actually trying to maintain people's health, like the original HMOs did,
Right.
you might have a point. But as it stands, what's happening is that companies are changing their insurance companies daily, monthly, whatever.
Yeah.
People are changing their places of work, losing jobs, gaining jobs, and changing. So there's no continuity in their care, and there's really no accountability then. So
What is your question?
My question is, why do you support those, and why aren't you instead working for a single-payer system?
Thank you.
So I think that we need an economic model like the single payer with this kind of concept of accountable care where there is, there's nothing capitalistic about the current insurance system. It's a rigged monopoly. There's no fiduciary responsibility on the part of the insurance industry. They can charge whatever prices. I mean, it is, I agree with you. I've got a lot of sympathy for your position. So I guess I'm recognizing that we have a tough enough time just getting the modicum of insurance regulations done to inform and enforce parity that will be good for insurance companies, and they're not doing it, right? So the notion that we're going to get, I guess this is where I show my age, that we're going to get to throw them all over the side and get a single payer. I will say that I think the future for government funding is going to be in these social innovation bonds, where you can reallocate dollars in a way that really gets the full covered life. Because now, as you said, people bounce from insurance company to insurance company and job to job, and there's no way for them to really want to invest in the long-term prevention because there's no return on that investment. I think we can come up with, I think we can put this to smart people to help us come up with new value-based models. Obviously, there's the biggest one is if you've got all the risk as a single payer would have for the whole life of the person. That's why a lot of Scandinavian countries do a lot better, because they know they're carrying the person forever. So they really put it into early primary care and health care. So I think there can be some way of employing that. I guess I'm saying I'm conceding that I don't feel as idealistic to throw the whole system over, but I think that we could probably get something closer to what you're saying. And what you're saying is we want the financial incentives to be aligned so that we get the results that we want. That's what we should all be about. And you could actually get Chamber of Commerce people support a notion like that if you put it to them like that. But if you say you want single payer, they think, oh my God, they're about to take away. It's a Soviet-style system. And unfortunately, I think culturally we're going to have an impossible time. But I think if you approach American people and say you could pay for it this way or you could pay for it this way. This way saves lives and it saves a ton of money. I think it's going to be hard for anyone to be ideological about, well, let me see what that's really called. I think, in other words, it's the positioning of this. I mean, that's where I think we could actually do something. Anyway, sorry for not answering the whole.
That's a good question. Yes, ma'am.
Thank you for joining us this evening. My name is Enya. I'm a second year in the college majoring in global studies. Immigrants in the U.S., both documented and undocumented, have serious limitations to healthcare access. Do you see this as a serious issue in the country, and why? And what hope do these populations have moving forward with the current healthcare reform?
So one of the big challenges is obviously immigration reform, because if you're undocumented, you've got a lot of problems coming out into the light, and it's a horrific situation for millions of Americans. I was addressing a group of migrant farm workers the night my dad passed away. I was doing speeches for him that he was invited to do and he couldn't do, and accepting all kinds of awards on his behalf, because everybody started giving him awards when they knew he had just gotten diagnosed. And one of the awards was from the United Farm Workers, and I went out and I spent the whole evening in this place where all the migrant workers came from. After it was out in California, and the horrific stories about not being able to, from being separated from family members, having these health crises. It would make anybody who is cynical about immigration change their views overnight if they heard these heart-wrenching stories. In any event, there's a lot to do there. I appreciate your asking the question.
Thank you.
Thanks. Yes, sir.
Hi, my name is Baxter. I'm a second year here studying public policy, and I just wanted to bring this a little closer to home for students at a university. And so you've worked on the national level, Affordable Care Act, and looking at the big picture, but I was curious about on an organizational level at universities, what can they do better to, fit into this new system that we need that you talk about?
Well, I'm glad you asked. The JED Foundation, JED, is the best that I've ever found to certify colleges and universities for having the most proactive mental health on campus. They have a whole set of criteria by which they judge a university's kind of adherence with the gold standard of mental health for students. We lose, nearly 2,000 college students a year to suicide. It's between third and second leading cause of death for young people. It is a major issue, and many colleges and universities just don't do what they know works. So it kind of goes to your question too, if you know someone who's in crisis. So I'd go up to the JED website and look into it. But there's Active Minds is a terrific club on campuses all over the country, where they really try to instill conversations about the importance of discussing these issues. The biggest challenge with all these issues is getting people to discuss in an open way. So that would be another suggestion. But your organization supporting veterans is fantastic. And the fact that all of you are just doing it out of your affinity for helping your fellows who are veterans. I looked around and said, this is a veterans support group. I'm going to walk in there and I'm going to have all these kids with multiple tours of duty in Iraq and Afghanistan. And then I'm like, well, what are they doing supporting veterans? They're not veterans. And I'm like, just criticize myself, because I'm like, my attitude is what's wrong with this country. It's like, you have to be that person to care about those people. And it's so uplifting to see you and Brian and all the rest of you part of this club to try to think of ways to improve the lives of returning veterans. Just fantastic. So thank you for doing that.
Thank you.
Thanks. Yes, sir.
My name is Brandon. I'm a fourth year at college studying political science. So my question is actually going to touch upon what you spoke about relating to decriminalization or legalization of not just marijuana, but all drugs in general. So looking at, in Portugal, there's a case, they legalized all drugs in 2001, and the country has not been, as many were fearing, overrun by addiction, but on the other hand, they actually have seen what I believe is a drop in the overall drug abuse by society in general. And while my knowledge on the subject's admittedly limited, I do think that those results should hold some bearing over perhaps the future policy in the United States. I was wondering what you think those results, how they impact your mode of thinking related to what can be done going forward, because it obviously has a great deal of importance in this country.
Sure. My big thing is that the public health can never compete against the big advertising of a commercial enterprise. I mean, they'll just, dwarf us in amount of money to make it sexy and glamorous and look good. And Lord knows, stress in the society is unbearable for people, and they're looking for a way to cope and manage their stress. And there's a reason we have an epidemic of addiction in this country. It's because, for folks, that's what we're acculturated to think like. We're, go have a beer, go out, go blow it out, and, let off some steam, blow off the pressure. I mean, everything in our mode of thinking is, if you've got stress, if you've got problems, there's a way to cope with it. And that way is not social-emotional learning. What the hell is social-emotional learning? I mean, it's not like problem-solving coping mechanisms. What? I didn't learn about any of that when I was growing up, What? I had all these stresses. There's actually a way to deal with it that's healthy? Like, no one gives anybody the guidebook to, manage. The default mode is get intoxicated. And of course, the medical establishment, the prescriptions of benzodiazepines and Oxycontin and everything else, I mean, that is it. We're just shoveling it on everybody. So, my feeling is, if we're going to be the greatest nation on earth, where we are freest people and we are able to make the most of all of our God-given abilities, it just seems to me you don't want to have to go at every corner and have advertising for vaping of THC 20% and this, and you could get the crumble, and you can get these are all ways of describing the new marijuana. Crumble, it's like crack, but it's THC, and you can and you can vape it and no one will know. You just put a little dab of that, and then you can drink your Red Bull with your elixir. And I mean, this is the whole where we're going as a nation. And I just think this whole argument about, we're, having to deal with drugs and alcohol and this all lock them up mentality, the opposite is not to legalize and commercialize. The opposite is, let's preempt these illnesses by not inundating people with messages that this is okay, and rather let's help them build strength-based resiliency. Let's not fall back on this false dichotomy that the default mode is just to legalize. And that's what people have come to think. Yes, the war on drugs had some really draconian responses, and we can fix those responses. But I don't think it means that to do so, we increase the addiction rates, because that's what ends up happening. The more prevalence, the more addiction. That's just that's also science. The easier the availability, affordability, and the like, the more people will use. That's also so. It's definitely worth a good, healthy debate, and I appreciate you bringing it up.
Of course. Thank you for being here.
Thanks. Yes, sir. Move close to the microphone, too.
Miles Zaremski. I'm a professor of law and healthcare. Gun violence, as we know, is a major, major problem in our country, and certainly in the city of Chicago, it goes without saying. And politicians, including those running for office now, will say that let's not look at guns, but let's look at mental health.
Yes.
And my question to you, Patrick, is what is your observation about that argument that we have to look at mental health to cure the gun violence in our country and certainly in our city?
Well, it's obviously both. But clearly those who don't want us to look and touch guns are all trying to focus our attention just on the mental health side, as if that's going to be the Heisman, keep it away from the guns. So, but it's both. it's closing the gun show loophole. It's doing all the things that we know, holding gun manufacturers accountable, getting rid of these huge semi-automatic guns. The whole, all of that's called in the safe gun policy, which is regulating the guns. Not taking them away, but regulating their access, because we clearly have an interest in doing that for the protection of everybody. So, but my view is if we can get the Republicans to move a major mental health bill, politics being what it is, it's hard to imagine that we're going to get, and I'm being really cynical, it's hard to imagine we're going to get a major gun bill doing all those things. I was the sponsor of the Brady bill in Rhode Island, the primary sponsor. I was the chief co-sponsor of the assault weapons ban in Rhode Island, and I led the charge against the repeal of the assault weapons ban in the Congress. But so I am all on the side of better gun control. But my feeling is if we can somehow co-opt Republicans' angst about us, going after guns, and we let them pass a mental health bill so they can pat themselves on the back and say that they did something about the scourge of violence because it was all driven by those with mental illness, then expediency what it is, we'll get a mental health bill out of them. Maybe it'll be good. Maybe we can get them to put some real dollars behind it. And try to do some things that would be useful to helping more people get access to treatment. I've had a number of my Republican colleagues now commit to enforcing the parity law. And I know I'd never get them to do that if they weren't feeling the heat to do something, right? And so if it gives them an out to do something on mental health, I want to make sure it's the right out. But I'm almost willing to give it to them if we can get something. And that's sheer cynical politics. But we are at the Institute of Politics, so I figure,
Thank you very much.
You bet.
Great. Yes, sir.
Michael Massal, Professor of Pediatrics and Co-Director of the Kennedy Research Center on Intellectual and Developmental Disabilities, named after one of the family members and the first Kennedy Research Center in the country. And I want to praise your book, which I bought and received.
Oh, great.
I didn't buy it. I received it as a present from my brother Lawrence.
Lawrence has been such a great supporter.
And your family has a wonderful tradition, starting with Eunice Kennedy Shriver and Robert Shriver, of paying attention to intellectual disability, previously known as mental retardation, and the other developmental disabilities, autism, epilepsy, cerebral palsy. And one of the real things about Obamacare is it really got rid of pre-existing conditions. Until recently, if you had any of those conditions, you were uninsurable as an adult. The second thing that nobody knows is that Obamacare made many of our successes in pediatric medicine, leukemia, cystic fibrosis, if you were an adult survivor of those childhood conditions, congenital heart disease, you were uninsurable. You could be the king of Spain and not get U.S. health insurance on those conditions. The real question is in terms of this equity for behavioral health, that we're so far from either having the capacity or the coordination of being able to do it. And you are so right that we have to keep on advocating for it. But I do know we've missed one point on the equity. And the equity point we've missed is not to shine the light on our state and federal officials who have much better behavioral health coverage than the average insurance carrier has. Do you have a strategy that you could make that happen?
Yeah. So as you know, as I write about in my book, the Federal Employee Health Benefit Plan that we were insured under as members of Congress obviously didn't cover our constituents. And that was part of the driving force that we made because there were a lot of my colleagues who got covered. In fact, but some of them got denied, even under FEHBP. I had a colleague of mine, a Republican, on the Commerce Committee, call me to ask me to intercede on his behalf to get coverage for an inpatient treatment that remained quiet to everybody. But he couldn't get it reimbursed. He was on the Commerce Committee. If you're an insurance company, this is like, they're the ones you like want to go to bed with every night. You know, you love these people. They regulate you. And they denied him for his inpatient while he's a member of Congress. And of course, he didn't want to do it because he didn't want to look like he's using his muscle as a member of Congress to force the insurance company to do it. So I said I'd do it for him. But I mean, the bottom line is, you know, we couldn't do that 24 hours a day. I would routinely run into friends of mine in 12-step recovery who are being denied left and right for services, and I would call up the lobbyist for that insurance company. I'd say, I'm about to go to the floor of the House and talk about this story, this person who's just been denied by your insurance company. Oh, wait, Patrick, just let me get back to you. Tell me their insurance number. Oh, we got it all set, you're fine. And, you know, I mean, I just, a threat of, you know, exposing them. And if I could do that all day long, 8 days a week, I would do it. But your point is right. There's an inequity here. They definitely get better, but, you know, we got a lot of work to go. I love your brother is the best.
So we've got about 12 more minutes, and we've got 4 questioners, and I'm going to play the role of whoever used to do that in the Congress, and I'm going to yield time, but you're only going to get a little time. So go ahead. Short questions.
I'm used to being cut off.
Go ahead.
Hi, my name is Kathy Powers. I am a member of the mental health movement in Chicago, a board member of the Northside Action for Justice, and a disability advocate for the state of Illinois.
Sure.
I don't know exactly. I think my point that I want to ask about is that in the mental health movement, we are trying to reopen the Chicago clinics, public health clinics. We need a safety net. There's many deserts in the city that don't have mental health coverage. And what we have found is that we who have recovered or are recovering and are working with advocacy really get subverted by nonprofit companies like the Health and Disability Advocates Group, which came out with a 35-page report about how the mental health clinic should be privatized. And nobody asked us. Nobody ever asked us. And I would like to say that I want to be asked, my group wants to be asked, and I'm sure across the country, we want to be asked. We know what we need. Sometimes we don't know what we need, but we discuss it. We have an open forum.
So is your question with the state budget issues, how can people get care?
Oh, you know, I don't even believe we can because the governor just cuts off the human services and laughs at it while he's doing it.
Yeah.
So my question is, how can we get our input? You
hit it, and that is that a lot of decisions are being made regarding these issues, and what they're doing is they're leaving out the people who are the consumers that folks ideally should be looking to help and the most, and that we should get the input of the consumer community in order to better inform what public policies are put in place. And it sounds as though, from your vantage point, that has not been done here, and that it really could benefit from having the engagement of people who are consumers with lived experience. And I think that's a great point.
And I'm a friend with AJ French, so there you go.
Awesome. Good.
Thank you so much for coming.
Great question.
Hi, Congressman. My name is Rod Ritchie. I'm a writer, and like you, I live with mood disorders and a mood disorder and addiction. My question to you is, if we're going to offer parity, we're going to have to deal with the perception that mental illness for some people is very subjective. You know, you could say to somebody, "Boy, I'm just going crazy," and what I'm saying is there needs to be an increase in the effectiveness of screening, of diagnosis, so that we can present to patients and to insurance companies saying, these people have been vetted, they've been scrutinized, and this is what their problem is. But right now, it's all kind of anecdotal when you go to a therapist. And I was wondering if that's a major part of your parity initiative.
It is. So if you log on to the Kennedy Forum, www.thekennedyforum.org, we have first payer accountability. That's enforcing the parity law with insurance companies. The second is provider accountability. And we really need to up our game in terms of measuring outcomes so that we know, as I said from the beginning, what works and what doesn't. And we measure what people's severity is and what is the appropriate form of treatment for their particular diagnosis and the severity of that diagnosis. And what we would get at is, you know, the difference between thinking we've got a problem and it really affecting our capacity to live functionally, right? All of this can be measured really down to the nitty-gritty. There's nothing soft about this. It's just a different set of metrics than medicine is used to. There are all kinds of biomarkers that you can plug into the IBM Smarter Planet computer to tell how someone's doing on the trajectory of functionality. And they're not purely medical or biological biomarkers. They're social biomarkers. They're community-connected biomarkers. There's all kinds of other stability biomarkers. That can be done today. And so no one should have this sense that there are a lot of people who are malingerers who really aren't real and they're clogging up the system and all the rest. Believe me, there will be a way to decide who's in need of care because they have real limitations because their illness is really impinging on their functionality, and who, you know, maybe need some good preventive care, but they're not all in the same bucket, so to speak. And that is incumbent on the professional provider class to get with it, to do all that. And I think we can convince both, because the insurance companies don't want to pay the providers because they don't think they're real. They're not doing the real job. They're not adhering to any outcomes-based metrics and all. I think this is a really good combination. You pay, and guess what? We're upping our game. So what you pay for will be actually verifiable and measurable, and there's going to be outcomes. That's a good thing. Both win. Payers get something, which is a great return on their investment with outcomes, you know, and providers get something, they finally get some money in their pocket. I mean, this is a great deal. We have to do it together, and now's the time, because, you know, the promise is there, we got to make it real.
Yes, sir.
My name is Dave Amara. I'm a psychiatrist working at Mount Sinai Hospital. Thank you for coming. I was actually trained here at U of C for residency, so go U of C. I have a two-part question for you. As you know, the Supreme Court is going to be making some big decisions regarding mental health law. And what are your thoughts about the current nominee, Mr. Garland? Is he friendly to our cause? Or the second question is, besides yourself, who would be a good vice presidential candidate for?
There you go. God, couldn't we finish up with you and you be the last question? Thank you for going into the field of psychiatry. You face enormous stigma going into the profession of psychiatry that your colleagues in medical school don't face in going into their specialties in healthcare. So thank you for taking that on. You also are subjected to all kinds of lower reimbursement that you wouldn't be subjected to if you were a physician with another specialty, given the same level of education that you have. So you're in it for the vocation, and we thank you for that. I honestly haven't looked at Garland's and read the tea leaves on how he would rule. And as far as vice president, I tell everybody that the only way I'm getting back into politics is as my wife's campaign manager. And I have a great story behind that I could tell another day. But we're from New Jersey, so real quick. I was teasing my wife about, when I had this local reporter ask me, Patrick, you gonna get back in politics? I said, no, it's only as my wife's campaign manager. She'd make a great candidate for governor. There's an election coming up. This is 5 years ago when Christie is running for re-election in New Jersey. So the reporter at all wrote it down. And my cousin Tim Shriver is head of Special Olympics International, and he's going in to negotiate with Christie the following week on bringing the National Summer Games for Special Olympics to New Jersey. So he has to get approval from the state on everything you can imagine, logistically. So he walks into the office and gets an earful about what does his damn cousin think he's trying to do, getting his wife to run against me. And so Timmy calls me up after the meeting. He said, oh, and the governor dropped all kinds of F-bombs on me and everything else. And Patrick, what are you doing? I said, that governor's got a better sense of humor than I ever imagined. And he goes, he wasn't joking. So we all know. So anyway, I don't know where that went, but so much for the vice presidential comment. Thank you.
Thank you. Hi, sir. My name is Jason, and I'm a third year at the college. I've personally struggled with mental health for much of my life, and so this is something that's very near and dear to my heart.
Good.
One thing that I was wondering was, you mentioned earlier that nobody has a good solution to any of the problems, and everyone turns to intoxication.
That's right.
No better place than college to start, right?
That's right.
And I've personally been exposed to people who have said things like, well, alcohol solves all my problems.
Right.
Or I don't feel comfortable socializing with my friends unless I'm partying. There are these things that keep us from actually connecting with our fellow peers. And one of the things that convinces people that we're actually together is alcohol.
That's right.
And then to top it off, for responding to the problems that arise from this, a lot of these measures are inadequate. And I've been hospitalized before, and I was hospitalized during my time at UChicago, and I did find that some of these measures were inadequate.
That's right.
What do you think universities should do to prevent people from falling down this slippery slope, to stop it from happening in the first place? Great question.
I honestly wish I had the answer to that. I think part of the answer is in the very fact that you self-disclose when you speak, and that you're very open about your struggles. And I think that's very disarming and invites other people to self-disclose and opens up a dialogue for you with people that you are surrounded by that may be suffering as well, and also holding it inside and not telling anyone, and may now find someone in you that they can connect with, so that you have a meaningful, intimate connection with some other human being who understands what you're going through. And that is real connectedness. That's what we're searching for when we want that fraternal bond of being able to connect with another human being. And by opening yourself up just like you did, and in a very transparent way, in a confident way, that is actually the answer writ small. You'll have to leave it to your officials at the university to think about adopting the best system, on a bureaucratic level, like I said, this JED Foundation and others that could help. But you are the answer in just the way that you pose that question to the problem. And you know what? All we can solve is, what we can do in our own lives. And in a sense, you are solving this dilemma by your own actions. So all the power to you.
Thank you so much, sir.
It's a great question. Great question. And our last question.
Hello, I am Michael Lynch. I'm actually a student from DePaul. It's in Lincoln Park. You probably know it. My question is, speaking on mental health, especially as an African American, what I see is when I got to college, I was exposed to all these things that I hadn't been exposed to as a child, such as mental health and other issues. So when I went to my school, I found that the counselors that the school had in place weren't equipped to handle illnesses or situations that are specifically, related to an African American's experience. So how can schools or insurance companies and other organizations make sure that it isn't only access to healthcare, but also access to healthcare that actually handles specific needs, such as African Americans, Hispanics, and other groups outside of, Caucasians?
Yes. Excellent point. First of all, stigma is a lot bigger within the minority community. Stigma is horrendous in the African American community, even worse in the Hispanic community, and even worse in the Asian community. So there's, everybody's got stigma, but some more than others, and having cultural competency. That's both having providers that are culturally aware of the particular issues that someone from a minority community has, one. And then having the cultural diversity in the provider community. And frankly, within the provider community, there isn't a whole lot of diversity at all. So it's hard. A good friend of mine is David Satcher, former Surgeon General, who wrote the seminal report, Surgeon General's Report on Mental Health. He describes how he was the only African American in the hospital when they had a psychiatric patient who was African American come in. And he didn't know anything about psychiatry, but all the other doctors said, you're the only one who can talk to him, who'll believe, who'll trust. And that was the beginning of a journey for David Satcher, and he ultimately became the top doc in this country. My point is that we are, in desperate shape in terms of making culturally available and sensitive mental health access for people in the minority community. And in the schools, which is the other part of your question, schools, education, mental health is an education issue. In 10 years from now, we'll be like, how in the world could we have let ourselves go so long thinking that kids could learn when we didn't address, panic, trauma, anxiety, depression, because there's no way for the brain to absorb information if kids have these undiagnosed mental health conditions, many of which are, especially in this city, are driven by the toxic stress that these kids grow up with, where they're hearing gunshots on a regular basis, where they see one parent, beating up another parent. I mean, we make a lot about how our veterans are suffering post-traumatic stress from being over in the theater of conflict in Iraq. Well, what do you call a theater of Chicago violence? And we're not talking about adults here. We're talking about children who are impacted. And we have trouble enough with adult soldiers coming back and addressing post-traumatic stress. And they have the ability as adults to have at least some manageability of stress. When this kind of violence affects kids, who knows what that impact is? And yet schools are absolutely ill-equipped to deal with this. So to your 2 points, one, we need more culturally aware and competent providers. And 2, we need mental health to be ubiquitous in our education system, because we check for your eyesight, your hearing, your scoliosis before you can go to school each year. Do we check for your anxiety, depression, addiction, mental illness? Those are the things we ought to be checking for first. And yet they're not even on the annual physical for kids before they go to school. You can't make this up, my friends. So the takeaway here is mental health is not just what you think it is. Mental health for people who, need treatment. Mental health is about our education system and allowing education to work. It's about our workforce and allowing our workforce to work more productively. And it's about all of us having a better quality of life just in general if we want the rest of our physical health to be better. So thank you for giving me that tee up to answer everything under the umbrella of your question.
Excellent. Well, with that, thanks to the University of Chicago Politics Institute for having us both, and thanks to the Congressman. It was great. And thanks to all of you for coming out. We packed it into a overflow room, so it was great. Thanks so much.
Yeah, before we close, and thank our speakers, I too want to thank all of you for being such a thoughtful and engaged audience tonight. I think we heard a call to action, and I hope we all pay attention. Bruce, thank you so much for leading the conversation, and please join me in thanking Bruce and Patrick Kennedy for speaking with us tonight.